And yeah, so that will be a different experience. And most of them, wherever possible, they will also be discussing cases from their own areas of interest. So this makes it unique along with the case conferences in your own institution. So I encourage all the PG teachers and the HODs to give a heads up on about this activity to their postgraduates, especially the last Wednesday, so that this 1 hour they can make use of. And yeah, as of now, uh, the participation from PGs remains still low. It is as of now, today it's 27. Hope this number will increase with motivation from the faculty. And anyway, I welcome you all for this second case conference of this year. And I hope it will be, I wish it will be a very enriching experience to all of you. Over to the coordinators, moderators, Anuradha and Yamini.
Thank you, sir.
Thank you, sir, and good afternoon, everyone. On behalf of Vydehi Institute of Medical Sciences and Research Center, I take this opportunity to firstly thank IPSKC for taking this wonderful initiative, in order to conduct this PG case conference. I would also like to welcome esteemed faculty members, senior members IPSKC, and most importantly, our dear postgraduates who are attending the case conference today. And to preside over today's case conference, we are privileged to have with us Dr. Kiran Kumar K, who's Professor and Head, Department of Psychiatry at WIMS and RC. Sir has done a lot of work in suicide, so he's basically looked into the gender differences in adolescent suicides. He's also done a lot of work in geriatric suicide. His other areas of interest are depression, and most importantly, like of late, sir is very much interested in undergraduate and postgraduate training. So I welcome you, sir. Our next chairperson is Dr. Swapna B. Madam is a professor and head of the Oxford Medical College, Bengaluru, and Madam's areas of interest are women's mental health, psychodermatology, and consultation liaison psychiatry. So I welcome you, ma'am. So yeah, I mean, before I hand it over to Yamini, so sir has already put up in the slide regarding today's case conference. So it's about the challenges, how when it comes to, discussing about the bipolar affective disorder in women. So yeah, I mean, I'll hand it over to Yamini, who would be moderating the rest of the sessions, and she will also be introducing our presenters.
Good afternoon, everyone. I'm Dr. Yamini, Assistant Professor in Department of Psychiatry. It gives me great pleasure in introducing our two speakers for today. These are two of our very own junior residents, final year. We have to my left, Dr. Anusha. Dr. Anusha would be helping us with understanding the history of presenting illness in this patient, along with mental status examination. To my right is Dr. Sneha. She will be helping us to understand the summary, the diagnostic formulation, and the management that has taken place for this patient. This particular patient was seen by the department in July of this year and has been thereafter been seen consecutively in the OPD setup. She's had one hospitalization at our institute. Beyond this, I would also like to highlight that this particular case will have an interesting twist to its narration because we will follow a longitudinal manner of presentation. This is keeping in mind the ease of understanding by doing so. Also, we will be taking a pause at the end of HOPI for all listeners to put in their questions into the chat box, which shall be heard out at the end of HOPI. We also would again stop at the end of mental status examination and finally at the end of the final presentation by Dr. Sneha. So we encourage that there is active participation through the entire case conference. Over to you, Dr. Anusha, for the rest of the presentation.
Thank you, ma'am. Good afternoon, everyone. Today I will be presenting history and MSc findings of our patient named Mrs. Harika. She is a 28-year-old female who is married and educated till BTech from a semi-urban background of Anandpur, and she belongs to a, middle socioeconomic status family. Her main informants were father and husband. Information provided was reliable and adequate for the diagnosis. She came to us with the following chief complaints of sleep disturbance since 4 months, irritability since 4 months, and suspiciousness towards husband since 4 months. The illness was acute in onset and episodic in course. Precipitating factor for this particular episode being birth of her babies, twins. It was a twin pregnancy. Patient was apparently maintaining well, then following the birth of her twins through LSCS, developed sleep disturbance and irritability 4 months ago. Due to the responsibility of feeding the babies every 2 hours and also due to the pain at suture site, she was unable to get adequate sleep. She had difficulty in initiating sleep when she tried and wake up even with slightest disturbance around her. Attenders noticed that despite inadequate sleep, she appeared to be energetic in the morning and did not appear drowsy and did not require naps in the day. Husband noticed the patient being irritable and tried to help her get sleep by taking care of other duties of the babies and feeding expressed milk instead of breastfeeding. Due to the stress involved in taking care of the twins, the couple hired a live-in nanny as per the advice of doctors. They also had patients' parents and in-laws moving in with them to help take care of the mother and the babies. Despite these measures to ensure adequate rest for the patient, husband noticed the patient becoming progressively irritable over the next week. Initially, she would snap at her husband and parents when they tried to advise her about self-care and baby care, saying that she knows what to do. As days passed, she started yelling over trivial issues like whether do they think that she is incapable and useless, that they keep giving her advice, etc. When attenders tried to calm her down, she would shout even more, bringing up past comments they made about her or supposed insults directed at her. Attenders noticed that it was difficult to interrupt her once she started talking, and she would jump from one topic to another, leaving them unable to understand where the topic started and in which direction it was going. Patient's behavior worsened, with her becoming aggressive by hitting her father and husband and using abusive and vulgar language. She also used to question their gazing at her, predominantly her husband, and angrily ask him to marry someone else if he is having a problem with her. Father reportedly said that patient used to talk high of herself, claiming that she can make them go to jail with one call to the Prime Minister. They also noticed that the patient was spending more time than usual praying and chanting to the God, playing devotional songs most of the day, singing and dancing to the tune. Patient also started being suspicious of the husband, accusing him of having an affair with the nanny. She would say that they were passing signals to each other through their eyes and gestures. She would accuse her husband of giving her tablets to make her sleep so that he can be with the nanny. Her husband and parents were unable to convince her that it was untrue, as she would accuse them of helping her husband to hide the affair and hit them for lying to her. There are instances of her being suspicious towards the nanny, due to which the nanny quit the job. Over the next 2 months, the patient's mood became unpredictable as she would get angry and hit her husband, and the next moment she would start crying, asking for forgiveness, requesting him not to leave her. Subsequently, she would also be affectionate towards the husband, and if not reciprocated, she would get angry again. Husband also noticed patient occasionally behaving in a way that was sexually suggestive, like hugging and kissing him in front of family members, which was not the behavior they had seen before. Patient's appetite was normal and her bowel and bladder movements were regular. During the episode, patient was able to bathe, clothe, and groom herself. Due to the above symptoms, patient was unable to adequately care for the babies, as she would get irritated when they cried. Initially, attenders started feeding the babies with express milk and formula feeds, but after 2 months, breastfeeding was stopped and completely compensated with formula feeds. Even though patient did not express any thoughts of harming the babies, and nor did she behave in a way that would threaten their safety, her parents and husband were apprehensive of leaving her alone with the babies and would take her out of the room if they noticed her getting irritated. Negative history. There is no history of fever, headache, blurring of vision, abnormal jerky movements of the limbs during the pregnancy. There is no history of any perinatal complication during LSES, no abnormal birth weight, birth defects, delayed cry, or failure to thrive noted in the children after birth. No history of excessive bleeding, fever, headache, or shortness of breath in the postpartum period. There is no history of over familiarity or overspending. There is no history of attempt to harm self or suicidal ideations. There is no history of hearing of voices, fearfulness, thoughts being inserted, withdrawn, or broadcasted. There is no history of belief that one's actions, emotions are controlled by an external agent. There is no history of lack of motivation, lack of emotional response, abnormal posturing, excitement, mannerism, stereotypies, automatic and passive obedience. There is no history of free-floating anxiety, episodes of shortness of breath with fear of impending doom. There is no history of episodes of unresponsiveness, multiple vague somatic pain, or substance use.
We've come to the end of history of presenting illness. We would like to invite any questions at this juncture.
What about the status during delivery?
Sorry, ma'am.
During delivery, did she had any problem? Postpartum. Postpartum, you have not explained.
Yes, ma'am. Ma'am, patient throughout the duration of her pregnancy was asymptomatic, but the symptoms started one day after the delivery, ma'am.
What was the behavior one day after? What was the behavior?
Ma'am, it started with sleep disturbance and irritability. It started with sleep disturbance because she had to feed the baby. She was not getting adequate sleep. And then it became irritability, and which progressed to aggressive behavior, anger outburst, excessive talking, and increased religiosity, talking big, making tall claims, and also suspiciousness towards husband.
It's also been asked if this pregnancy was a planned one.
Ma'am, it was not planned, but it was not a planned pregnancy, ma'am, because prior to the detection of pregnancy, she was on mood stabilizer. So they didn't discuss it with their treating psychiatrist or their doctor before the pregnancy about continuation of medication or anything.
Dr. Sindhu wants to know about the suspicious behavior which started within 4 months along with mood symptoms. She possibly wants to know the sequence of events.
First, it started with irritability, then increased psychomotor activity, aggressiveness, and then came the suspiciousness. Initially, it was just accusation, but later it progressed into becoming a fixed belief.
Kasturi ma'am also wants to know about the drug history, the treatment history. Ma'am, we'll be coming to that, ma'am. Ma'am is specifically asking us about the treatment history during delivery, and which she also means during pregnancy. We'll be coming to all of that, ma'am.
What was the fixed belief here?
Sir, unfaithfulness of husband, that he's having an affair.
But then she would also become, okay with him, and there was a line that mentioned, she would want husband to be close to. I mean, it was probably not, showing the fixed belief, whatever behavior you had mentioned, isn't it?
And sir, initially,
Yeah.
Andrea, there was only accusations. Sir. Then later became fixed belief. But also at the time, her behavior it was variable, sir. It was
Huh.
not consistent. Sometimes she would be affectionate, sometimes she would be angry, and if he did not reciprocate, then she'll accuse him of it. And later it became that she was accusing him of having an affair, uh, sharing gazes or signals with the nanny.
But then there was a public display of emotion also with the husband trying to be close with him.
Yes,
So
sir.
how to account for this in the background of this, suspiciousness on him?
Sir, and the despite the suspiciousness, sir, sometimes she would be like, "Don't leave me and go. Don't have an affair." She would cry to him. She would ask for forgiveness because when she hit him or screamed at him, then next moment she would be like, "I'm sorry. I should not have said that." And then she would again ask for his forgiveness. But when he didn't reciprocate or when he didn't say it's okay, no problem, then she would be like, "You're having an affair. That is why you're not accepting my apology."
Okay. So possibly there are some inconsistencies, isn't it?
Yes, sir. There is
Because
inconsistency in
because
behavior.
she would still try to care for him and try to be good to him.
Yes, sir.
Hmm. Yeah.
There's another question. Was she aware that it was a twin pregnancy during AMC visits? And did she know of the gender of the twins?
She was aware that it was a twin pregnancy, but she did not know about the gender.
Is this the first pregnancy? Any clear mood symptoms apart from special claims of calling up the Prime Minister?
This is not the first pregnancy. She has had a previous history of miscarriages. Other than this, as I'll be discussing in the past history section, there were previous episodes as well, which we'll be discussing next.
Any mood symptoms that were seen during pregnancy?
No.
One last question from Kasturi ma'am is, what was the grandiose delusion? Would you want to elaborate on the delusion?
Ma'am, tall claims were there, ma'am, but I wouldn't say it satisfy the criteria for grandiose delusion. Sometimes she would make tall claims like, "I can call the PM," if they try to stop her or try to convince her, then who you are talking to? I can call the Prime Minister and I'll make you all go to jail for torturing me. She would say things like that, but it was not consistently present. Only occasionally, once in a while.
I think we'll go ahead with the presentation now because there's a lot of new revelations that will come up. So, Dr. Anusha, please carry on.
Past history, as we can see here from the life chart, the onset of illness was 10 years ago. That was in 2015 when she was 18 years old. Precipitating factor for the first episode being joining to a hostel, and she was having difficulty adjusting. The episode lasted for a duration of 10 days. and it was characterized by sleep disturbance, increased talkativeness. At that time also the tall claims like the PM has congratulated me for being an excellent student, and also hyper religiosity, again with excessive praying and uh, playing of devotional songs, etc. And also she had crying spells and death wishes that were expressed to her parents through a telephone call. This first episode, patient was hospitalized and she was treated, but for we don't have any prescription or treatment history is not reliable. But in the intervening period, attenders report that after resolution of symptoms, she was consistently on tablet aripiprazole 5 mg for a duration of 4 years until the second episode in 2019. In 2019, patient moved to Chennai for work. She was in the training period, and due to work-related stress, she started developing sleep disturbance. She had crying spells, and she reported of depressive cognitions, like feeling worthless, and she was feeling helpless. She at the time also she expressed death wishes. This episode, they say it lasted for about 3 weeks, and the second time also they consulted the same psychiatrist. We don't know the medication or treatment history for this episode, but she started making recovery and was symptom free. The resolution of symptom occurred by around 2.5 to 3 months. And again, in this intervening period, she was still taking aripiprazole 5 mg as per the attender's knowledge. And she got married in the year 2020. And in 2023, she suffered a miscarriage in her first trimester. And also, she lost her job due to COVID-related recession. And she started developing this episode was characterized by sleep disturbance, irritability, aggression, tall claims, hyper religiosity, crying spells, depressive cognitions, and death wishes. So this episode is again suggestive of a mixed episode. And for this episode in 2023, she was treated with aripiprazole with dose up to 30 mg, and later tablet oxcarbazepine 900 mg and tablet risperidone up to 8 mg was also tried. The episode duration lasted for about 8 months, and medications were continued for a further 6 months. And when her twin pregnancy was, when she conceived, twin pregnancy was conceived, she contacted the psychiatrist on phone and asked for his advice about continuation of medication. And she was told to discontinue the whatever these medications that she was taking, and it was abruptly stopped. The 2025 episode is what we have seen in the history and HOPI that I have told before.
Yes.
Yes. The treatment history, treatment history for the first and second episode clear during active symptomatic period. We don't know, we are not, records are not available to see what treatment was given. But in the intervening inter-episodic period, attenders orally report that patient was given tablet aripiprazole 5 mg per day, and she was compliant with the medication for all these years from 2015 to 2019, and she continued it till 2023 as well. So this is the treatment history of the patient that is available to us from the third episode. She was started on aripiprazole monotherapy with a maximum dose of 30 mg for a duration of 2 months. with aripiprazole only, her sleep improved, her aggression and mood symptoms did not, and suspiciousness did not improve. So she was added on tablet oxcarbazepine with a maximum dose of 900 mg, and risperidone was also added a month later. Plan was to aripiprazole was slowly tapered and stopped, and she was continued on oxcarbazepine and risperidone. With risperidone 8 mg, she developed oculogyric crisis. So they added tablet THP for the same as well. For the entire duration of third episode and after the resolution of symptoms, she was continued on tablet oxcarbazepine, risperidone, and THP until the conception. And after the fourth episode, after onset of symptoms following childbirth, she was restarted on oxcarbazepine and risperidone, which was later changed to eslicarbazepine. Since there was persistence of symptoms, endoxifen was also started and it was continued for a period of 1 month. When the patient came to us, she was on eslicarbazepine 800 mg, risperidone 6 mg, THP 2 mg, and endoxifen 16 mg. At the time when she came to our institution. Medical history. Patient is not a known case of hypertension, diabetes mellitus, bronchial asthma, seizures, hypothyroidism, or hyperthyroidism. Obstetric history, she's para 2, living 2, and 2 abortions. History of ectopic pregnancy with laparoscopic resection in 2022 at the age of 24 years, and history of spontaneous miscarriage in first trimester in 2023. Spontaneous conception and live birth of twins through elective LSCS in March 2025. Breastfeeding or express milk feeding was continued until 2 months, and it was completely stopped after 2 months. Menstrual cycles have not yet resumed post-pregnancy. Family history. As we can see from here, there is no known psychiatric illness in the family that is reported either by the father or mother that they're aware of. She is the second born child of parents with non-consanguineous marriage. Currently, she had 2 miscarriages and 2 live birth, that is twin pregnancy in 2025 of March. Family history. Patient is second born out of non-consanguineous marriage. Father was the nominal head of the family and he was the primary breadwinner. Parenting style was predominantly authoritative style. She had a conservative upbringing with a close relationship with father. Parents have adequate knowledge about the illness and they have supportive attitude towards the patient. Over-involvement being the predominant expressed emotion from parents. There is no history suggestive of any psychiatric illness in the family. There is no history of suicide or unexplained runaways in the family. Marital history. Patient was married 5 years ago in 2022 in an arranged marriage setup. Patient's wishes were considered in finalizing the decision. Husband is a software engineer by occupation. The couple lived with in-laws for the first year of marriage and they moved to Bangalore 4 years ago in view of their occupational requirements. Husband and in-laws were unaware of the illness prior to the marriage. Husband is understanding about the patient's illness and is supportive emotionally and financially for any treatment that she is undergoing. Temperament. Patient had moderate energy levels. She was slow to adapt to new environments. She had a slow and hesitant approach low threshold for criticism, predictable rhythmicity in day-to-day activities. Predominantly, she had negative mood, that is being anxious, with low distractibility and normal attention span. Personal history, it's birth and early developmental history. Antenatal period was uneventful. Birth history, full-term normal vaginal delivery. She cried immediately after birth. Postnatal history was uneventful. Developmental milestones were attained appropriate for age. Personal history, childhood and adolescent health. Patient completed her schooling with above average performance. Chose BTech course voluntarily. Focused mainly on studies and spending time with friends. Her social circle mainly consisted of cousins and limited friends who were unrelated. She made friends with deliberation and was able to sustain friendships long term. There is no history of thumb sucking, nail biting, temper tantrums, hyperactivity, inattention, inability to make eye contact, poor scholastic performance, defiant behavior, lying, stealing, damaging property, or substance use behavior during adolescence. Educational history, age at start of schooling was 4 years and the maximum grade reached was BTech, that she is graduate. Relationship with schoolmates is cordial with sustained contact with friends from school. Occupational history, after completion of her BTech, she got selected in a campus interview and moved to a different city for work, that is Chennai and Pune, for a software company. She continued to work in the same company after marriage. She was asked to voluntarily resign from the job due to lack of any upcoming projects following COVID in 2022 and 23. Sexual history, age at onset of puberty was 11 years. Menarche attained at 13 years. She had regular cycles.
Before we go ahead, we would like to call upon Dr. Swapna ma'am to kindly put forth her questions at the end of History of Presenting Illness.
Yeah, thank you, Dr. Yamini. So this was a very comprehensive presentation, Dr. Anusha, but I had certain doubts regarding the thing. Because HOPI, most of the things have been clarified. I would like to know, like you mentioned, the third episode lasted for 8 months in 2023. Am I right in understanding that?
Yes, ma'am.
Yeah. Would like to know, like, what are the symptoms that got improved in the beginning, and then what was the thing that residual symptoms that lasted for such a long period of 8 months?
Ma'am, long-term symptoms being irritability and lability of mood, ma'am, mainly.
What was the compliance with the medications during that period? Because 8 months is something which usually with the medications doesn't long for such a long time. That's the reason I was just.
Yes. From the information available to us, they followed up with their psychiatrist every month, and it has been mentioned and also confirmed by the husband that she was compliant with the medication.
That's good. So another thing that I had, I think, is like 2 abortions you mentioned.
Yes, ma'am.
And this is the third time that she has had a pregnancy and delivered the twins.
Yes,
any hormonal treatment was sought? Because 2 abortions, definitely they would have visited the gynecologist and retained the pregnancy. Any issues with her cervix? Anything?
Ma'am, they had done routine investigations, etc., but they didn't seek for any hormonal abnormality, any IVF plans. That was not done, ma'am. Hormonal workup for IVF, anything like that was not done. They're just a general consultation with routine investigations were done.
Okay. So yeah. Another thing is the second episode of the thing, like in 2018, right?
Yes, ma'am. 2019.
2019, sorry. So it was only which lasted only for 8 weeks and had more of the depressive symptoms.
Yes, predominant. Yes, ma'am. It is depressive symptoms.
And was treated, but we don't have the treatment history. What was given and all.
No, ma'am. Since patient previously had a mixed episode, suggestive of mixed episode, and they went to the same psychiatrist back, where might have been stabilizers, but we don't have any record of it, ma'am.
Okay. These were the things that I had doubts. Maybe we can further cut. And I think there are a lot of questions in the chat box also, which can be answered at this point of time. Yeah.
What we'll currently do is probably continue with the mental status examination and general physical examination. And ma'am, at the end of that, we will open the forum again for questions.
That sounds good. That sounds good. We can continue with that.
General physical examination. Patient is conscious and grossly oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Her pulse rate was 90 beats per minute, BP 110 by 80 mmHg, weight 49 kg, and her BMI is 22.3 kg per meter square. Systemic examination. CVS S1, S2 was heard. There was no murmurs. Respiratory system, bilateral normal vesicular breath sounds and no added sounds. Per-abdomen examination, soft, non-tender, and there was no organomegaly. CNS, sensory system, motor examination, cranial nerves, and cerebellar functions were all normal. Mental status examination. Initially, at the time of presentation, general appearance and behavior of the patient. She's moderately built and nourished, well kept, appropriately dressed, appears distressed, and is aggressive towards her husband for bringing her to the hospital, and is also hostile towards the staff. Rapport was not established. On verbal de-escalation, becomes clingy towards the examiner, trying to hold on to them for physical support, crying on their shoulders, and trying to hug them. She does not maintain eye contact, easily distracted by small sounds, gets angry easily when she is contradicted. She's grossly oriented to time, place, and person. There was no tics, stereotypies, or mannerisms noted. Sorry, ma'am. Her speech, there was spontaneous speech with normal tone but increased tempo and volume. It was coherent but irrelevant to the question asked. Her mood, subjectively, she said bagaledu. Objectively, it was dysphoric mood. It was incongruent to the thought, inappropriate to the situation. There was increased intensity, and it was affect was labile. Thought at the time of admission, and when asked why she is here, she started with, my husband brought me here by force. He is forcing me to leave the babies. He is a bad person trying to get rid of me. He does not love me. And then she heard an aeroplane sound in the ward, and she said that aeroplane is flying. I will fly in aeroplane and go to America with my husband. Let me go. I don't want medication. Give injection to him, etc. From impression, tangentiality is present. In content, she reported suspiciousness that husband is being unfaithful. She remained unconvinced despite contradicting her on further questioning and providing proof and reassurance, acting out by being aggressive towards the husband. And she gives implausible explanations, like she saw them passing signals from their eyes as to why she has the beliefs. On assessment, the belief appears to be false fixed belief, and it is inferred that delusion of infidelity is present. Perception, there was no abnormal perception. At the time of admission, her judgment, personal, social, and test judgment were impaired, and she had no insight into the illness.
We pause at this moment. We again invite the audience for questions. I would request the postgraduate students to also be equally enthusiastic in asking questions. So kindly unmute yourself and feel free to ask questions.
Dr. Yamini, there are a few questions in the chat box. You can address that as well.
Sure, sir. There is a question here which says, what was her personality between episodes? And was there any psychosocial issues? I think what they would want to know is perhaps the personality traits that the individual embodied, because there was emphasis on temperamental traits so far. And also if there were any significant psychosocial issues that the patient was dealing with just prior to this episode or during the episode.
Between the episode, from what we could understand, she had low self-esteem, and she also had low tolerance for criticism, as seen with her interaction with her husband during the marriage. But we didn't do a formal personality assessment for her, as she was symptomatic at the time. But from history, we could get that she had low self-esteem and had low tolerance for criticism.
Any psychosocial issues?
Psychosocial issues, I would say not much, because in interpersonal relationships, she was very shy and timid, and she is more submissive. Who, if you tell her something, she would accept it without questioning or without showing any she would usually go by what others are telling her, be obedient, and does not talk back against her elders or people who are authoritative figures.
Apologies from our side. Due to technical hassles, I think the chat box have got cleared out. So those who had posted their questions, kindly unmute and ask your questions. Anything that hasn't been answered so far?
Dr. Kasturi Madam wanted to know how was her behavior towards her twin children?
As we said, ma'am, her symptoms started second day after the LSCS. Her behavior, she wanted to take care of the children, and she reported she had care and love towards the children. But since she had irritability, she was not able to tolerate, she was not able to do some of the things, because the children would cry when she's feeding, or they would move their hands around. They would not stay still when she was changing their diaper, etc., which is expected of children. But due to her irritability, she was not able to adequately care for them. Normal behavior of the children, she would get upset easily. And because the attenders were also very apprehensive of leaving her alone with the child, there was not too much bonding time with the children, or no play with the children also. Adequate enough time to play with the children.
Was there any risk of harm to the children, Dr. Anusha? That was the question, probably.
Yes, sir. And as I also mentioned in my HOPI, that the patient did not express any negative thoughts towards the children or express any intention to harm them. but it's
The other question that's popped up is by Dr. Adarsh. He says that in the MSc, the thought is the speed sample good enough to come to a conclusion or an impression of tangentiality? Your opinion, Dr. Anusha.
I don't think it is a good enough speech sample, but at the time when patient was symptomatic, we just recorded what we could get.
Just like to highlight that the mental status examination was a compilation of findings over a course of 1 week. Because the first day, of course, the patient was very irritable. But we were able to establish some sort of rapport over the course of a week. Anything else?
I had also posted one question in the chat box. So what was the initial diagnosis after the first episode?
Sir, that we are not aware of, sir, because they don't have any record. But from the symptoms that they were telling, it was inferred that it was a mixed episode.
Okay. And the second one was a breakthrough episode?
Sir, to call it she was not on adequate dose of mood stabilizer. She was just on aripiprazole 5 mg. And again, for that, compliance is not completely established because she was not in her hometown. She was living in a different city along with her cousin. So we are not able to establish compliance. So we don't know if it was a breakthrough episode.
So was there any change in the diagnosis after she came for a second episode in 2019? From mixed episode, did it change?
Sorry, sir, I didn't understand your question.
So the diagnosis changed in the second episode?
No, sir. Since it was the same psychiatrist who treated her, but there was no, I think there was no change in now.
So it was bipolar disorder?
Yes, sir.
Yeah, the other thing was I thought about tangentiality anyway, somebody has asked.
Response to stopping breastfeeding.
There's another question, which was a response to stopping breastfeeding by the mother. Did she experience guilt regarding the same?
So retrospectively, when we interview the patient in OPD, she does not express such kind of guilt.
Another person also wants to know if there were any scales applied. We will be discussing that subsequently with Dr. Sneha taking over. Any other questions at this juncture?
During which trimester the medications were stopped during the pregnancy, just when she got conceived and she called the psychiatrist, or they took some time because you mentioned it was abruptly stopped, not tapered down?
Yes, ma'am.
After how many, like which trimester?
It was in first trimester, ma'am. She was around between 5 to 6 weeks.
Thank you all for your questions. Anusha, you can just wrap up this last bit of your presentation. So we hand it over to Dr. Sneha.
Cognitive functions. Cognitive functions were tested after once the patient became more cooperative. Orientation, she was oriented to time, place, and person. For attention and concentration, she was able to remember digit forward up to 6 digits and backward till 4 digits. and attention was easily aroused and sustained. Memory, immediate memory assessed by digit span test, it was intact. Recent, she was able to recall events in the past 24 hours, which recent memory was intact. Remote, she was able to remember year of her graduation, date of her marriage, and date of birth of her children, which indicates that remote memory was intact as well. Intelligence, she was able to answer the Prime Minister of India was Dr. Modi, and capital of Karnataka being Bangalore. General fund of information was appropriate for her age and background. Simple arithmetic, she was able to do simple addition, subtraction, multiplication, and division up to triple digits. Comprehension, when asked what she will do when she feels cold in the hospital, she replied that she will cover herself in a blanket. Abstract thinking, she was able to say the difference between TV and radio, that one is a visual media, another is only audio. And she was able to say similarities between apple and banana, that both are fruits. And she was able to describe the proverb, all that glitters is not gold. She was able to explain that just because something appears shiny does not mean it's gold. It also alludes to the nature of humans too, that just because someone talks nicely does not mean that they are good. So it was inferred that her abstract thinking was intact as well. Judgment, personal judgment was intact. She says that she wants to go back to take care of the babies and play with them and apologize to her husband and parents. Social judgment, she was behaving appropriately to the environment that she was in. Test judgment, when asked what she will do if a fire breaks out, she said that if it's a small fire, we'll try to put it out, and if it's a large fire, she will call the fire department. So it was inferred that her personal, social, and test judgments were also intact.
Thank you, Dr. Anusha. Now we have Dr. Sneha take over.
Good afternoon, everybody. I'll be discussing summary, diagnostic, formulation, and management. Mrs. H, 28-year-old married female.
Dr. Sneha, sorry to interrupt. You can put it in slideshow mode, please.
Okay. Sorry. Mrs. H, 28-year-old married female, BTech graduate, currently unemployed, mother of twins, that is one male and one female child, belonging to middle socioeconomic status, residing in Bangalore, with slow to warm up temperament, no significant medical comorbidities, and no family history of psychiatric illness, presented with an onset, with that acute onset episodic illness, with a longitudinal history of illness course beginning at the age of 18 years, characterized by 4 episodes of mood disturbances, predominant polarity of mixed affective episodes, 2 mixed, 1 depressive, and 1 manic episode, consistently precipitated by psychosocial and biological stresses, that is hostel stress, job stress, miscarriage, postpartum period, with good inter-episodic recovery and good functioning on maintenance treatment. The first episode at the age of 18 years, symptoms suggestive of mixed episode precipitated by hostel stress requiring hospitalization, with good response to tablet aripiprazole 5 mg OD, with query injectable antipsychotics in the acute phase. That there is a missing information regarding the maintenance and the continuation phase. The second episode at the age of 22 years, and the symptoms suggestive of depressive episode precipitated by job stress, and she was on a tablet aripiprazole 5 mg OD and continued it for 4 years subsequently with good compliance. The significant life events following ectopic pregnancy at the age of 24 years and spontaneous miscarriage at the age of 25 years. As it's a query antipsychotic induced, as the patient was on aripiprazole 5 mg OD at that time. The third episode at the age of 26 years and the symptoms suggestive of mixed affective episode responsive to antipsychotics, that is aripiprazole was tried till 30 mg and risperidone was tried till 6 mg, and mood stabilizer, that is oxcarbazepine, was tried till 600 mg for 1.5 years. And oculogynecologist achillogaric crisis was also noted after adding risperidone 2 mg, but the improvement was also seen with tablet THP. The fourth episode, which was a current episode, was in the background of stopping medication in view of natural conception, which was accidental at the age of 28 years, and abrupt stopping of medications with subsequent LSAS delivery of twin pregnancy in March 2025. The patient developed symptoms within 1 day postpartum characterized by pervasive irritability with verbal, physical aggression, sleep disturbance, mood lability, and impaired functioning accompanied by delusion of infidelity, resulting in significant dysfunction in self-care, childcare, and interpersonal relationships. On mental statal examination, rapport was not established, increased psychomotor activity was seen, pressure speech and irrelevant speech was seen, irritable mood, labile affect, delusion of infidelity, tangentiality, poor judgment, and lack of insight. And on physical examination, the BMI was seen to be 22.3. Prior to visiting the psychiatry team at WIMS and RC, adequate trials of antipsychotics, that is risperidone till 8 mg, mood stabilizer, that is oxcarbazepine till 900 mg, and then shifted to eslicarbazepine 800 mg, and adjunct agent of endoxifen till 16 mg were tried with no response. This is the end of the summary.
We've come to the end of the summary and we'll go on to diagnostic formulation now.
Formulation, Ms. H, 28-year-old married female BTech, currently unemployed, mother of twin, belonging to middle socioeconomic status, from Bangalore, with slow to warmer temperament, no significant medical or psychiatric comorbidities, no family history of psychiatric illness. Presented with acute onset episodic illness, characterized by irritability, insomnia, delusion of infidelity, with past history of 2 episodes of mixed nature in 2014 and 2023, and 1 depressive episode in 2018, with each episode precipitated by a significant stressor and life events with good inter-episodic recovery. Patient was treated with adequate trials of oxcarbazepine, eslicarbazepine, that is 900 and 800 mg respectively, with elbiprazole up to 30 mg, and risperidone 8 mg, with good response to oxcarbazepine and aripiprazole. Patient had developed oculogyric crisis with risperidone.
Sure. Now on to the management that's done at Vydehi. At this juncture, the differential diagnosis is as follows.
The differential diagnosis were bipolar affective disorder, current episode mania with psychotic symptoms, and schizoaffective disorder.
Okay, Yamini, before we go to the management, would you like, I would like Dr. Sneha to make us understand what were the features in favor of bipolar affective disorders and what were the features probably in favor of schizoaffective disorders in the current patient.
Sir, when the patient came here, we gave her a diagnosis of bipolar affective disorder, current episode mania with psychotic symptoms, because patient came with symptoms of irritability, psychomotor, increased psychomotor activity, pressured speech, irrelevant speech, labile mood, and irritable affect, with the sleep disturbance, then distractibility, impulsivity, with the psychotic symptoms being delusion of infidelity. So this was the diagnosis, which was the diagnosis we made initially when the patient came here. But because there was an the 2 things which actually says that the diagnosis goes towards the schizoaffective is that the disorganized thinking that is being the tangentiality, then also the incongruent psychotic symptoms. So this is the differential diagnosis I'm thinking, because patient presented with these core symptoms which can suggest, and the patient also had a duration of more than 1 month, which also gives a diagnosis suggestive of schizoaffective disorder.
Anything to suggest mixed episode in the current episode? Mixed symptoms in the current episode?
So the current episode, it was a mania symptom, sir. The previous symptoms were suggestive of mixed episodes, sir. 2 mixed episodes and 1 depressive episode.
Up.
Dr. Swapna, ma'am, any questions so far, ma'am?
Yeah, regarding the cognitive functions when Dr. Anusha had presented, she mentioned that judgment is fine, all the three. Whereas in the diagnostic formulation, we went and Dr. Sneha is mentioning that it was impaired. So can I have some clarification regarding this? When was the cognitive functions test was done? That's what I would like to know.
Ma'am, since when she came to us, she was acutely symptomatic. From her behavior and from interactions, we considered the judgment to be impaired because there was a disinhibited behavior, inappropriate behavior. Later, after the treatment, when patient started recovering, when the cognitive function tests were done more thoroughly, when she was more cooperative and with resolution of symptoms, her judgment also improved, ma'am. So this cognitive functions tests were done at the time of admission and also like after 1 week.
So your cognitive functions you are presenting in your presentation at the time of discharge or after 1 week of the admission.
Yes.
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 Okay.
Yes.
And I didn't get, like you mentioned, that attention is lost and concentration is well sustained. So I would like to know, like, how did you test the concentration in this? What test did you do?
Ma'am, digit fan test.
Digit forward and backward. Then that will tell you about the attention.
Yes, ma'am. And ma'am, simple arithmetic issues, mental calculations, some up to triple digits, and serial subtraction.
Yeah, serial subtraction, right? That which you missed in this higher cognitive functions, right? So that's what I wanted to. Yeah, over to Yamini. You can continue, and then later on we can look into the chat box and ask the queries. Yeah.
Thank you for your question, ma'am. I think the same question has been raised by 2 other I think the judgment. So thank you for the clarification from our speaker. So Dr. Sneha, you can continue with your presentation.
So the management, I'll be discussing the management. The patient was admitted under us, the IPK was given under the Mental Health Care Act, that is MHCA section 89, as patient had poor insight and no capacity, severe mania with psychotic symptoms and aggression towards the caregivers and compromised baby care. The psychometric assessment which were done at the time of the admissions were Young Mania Rating Scale, which showed a severe mania with 31 scoring. And the second one, Edinburgh Postnatal Depression Scale, was administered to screen the postpartum affective symptoms, and no depressive symptoms were noted. The investigations were done, that is the CBC, serum electrolytes, LFT, RFT, FBS and PPBS, and TSH, which showed the normal within normal limits. The pharmacological management which done, the initial medications which were given were risperidone, tablet risperidone, which was titrated up till 8 mg per day, and tablet THP was optimized till 8 mg, and tablet carbazepine was used. It is 9 mg, which was kept as a mood stabilizer, And the tablet endoxifen was also given as an adjunct agent for mania symptoms. And tablet diazepam was given for a short term for agitation and sleep, later which was tapered and stopped. Despite adequate trials and dose escalation, response to pharmacotherapy alone was seen with minimal improvement. So patient underwent 5 sessions of modified ECT, bitemporal ECT, with the progressive titration of stimulus parameters. Patient showed significant clinical improvement, that is YMRS score was 0 at the time of discharge. The maintenance and the OPD follow-up, that is post-discharge course, the patient was reviewed regularly on OPD basis, 6 reviews were done till now. Some residual symptoms were noted in the second follow-up, that is 20 days after the discharge. It is episodic irritability, occasional suspicion towards the husband, transient crying spells related to worries about the children. So in the continuation or maintenance phase, we added with risperidone 8 mg, eslicarbazepine 800 mg, and endoxifen 16 mg, THP 2 mg. We added lithium, that is 600 mg, and the plan was to optimize with the lithium and stop eslicarbazepine. And tablet clonazepam 0.5 mg SO is also given for oculogyric crisis and agitation. The maintenance investigation was done, that is the serum lithium, which showed 0.7 milliequivalents per liter. The future plan being the psychotherapy, that is adjunct with psychoeducation, supportive psychotherapy for stress reduction, nutritional advice, and physical exercise, family intervention for negative expressed emotion, shame or stigma, and interpersonal social rhythm therapy. At spaced interval, we want to do psychoeducation for bipolar disorder course, relapse prevention, and sleep hygiene, symptoms relief and relapse assessment, watch for mood switches and postpartum vulnerability, monitor medication adherence and tolerability, management of caregiver stress and interpersonal issues, lifestyle regulation, that is sleep-wake cycle, social rhythm stabilization, stress reduction, nutritional advice, and physical exercise.
As we come to the end of the presentation, of course, Dr. Sneha will also highlight certain good and bad prognostic factors in the patient towards the end. But right now, we would again throw the floor open to questions, both by our chairpersons as well as the rest of the audience. So kindly feel free to unmute and ask questions.
Whether in the past, any time the lithium was given earlier, or this was the first time you were about to try lithium for this patient?
This was the first time the lithium was tried, ma'am. The patient was sorry, sir.
Continue, Dr. Sneha, please continue.
Yes. Yes. So patient was initially tried with oxcarbazepine, ma'am. She was tried till 900 mg, then shifted to eslicarbazepine, that is 800 mg. But with these medication and risperidone 8 mg, the patient showed minimal improvement, and with ECT showed good improvement. But with the follow-up 20 days after discharge, she showed irritability and crying spells, and so we decided to add her on lithium till 600 mg. With this, she reported good improvement.
Because the first episode being query mixed episode, do you think she would respond well to lithium when you're looking to lithium responders and non-responders? In which category does she fall in?
Ma'am, the first episode being in 2015, ma'am. Yes, ma'am. Ma'am, the first episode being a mixed episode, lithium would not be a good choice.
Considering all the content of the patient's profile, the kind of course of illness that she had the next episode, her risk factors, do you think that she would be a lithium responder or a non-responder?
She will be that is the first line of management for the mania would be lithium, ma'am. But in this patient, she had a mixed episode predominance bipolarity, and for which lithium is not the first line of choice according to the CANMET guidelines. So I would not suggest lithium for the patient, ma'am.
What you would think of the management skills? What stabilizer you would consider that?
Ma'am, for mixed episode, typical antipsychotics and divalproex is the first line of treatment, ma'am, according to the CANMET guidelines. So aripiprazole, olanzapine can be tried, ma'am.
Okay.
Somebody has asked a question, why not olanzapine? Why is that you did not consider olanzapine? Because there was ocular crisis with risperidone and it was continued. Why not olanzapine and why not we reduce risperidone?
So when the patient came to us, she was on risperidone, sir, and she showed good improvement with risperidone. So the plan was to continue risperidone, sir.
Why not olanzapine? Think about the side effects, think about the tolerability, think about the long-term use of olanzapine. So would you like to reduce risperidone? Would you like to add on olanzapine and see what can be done in this patient? Those are the thought process probably will have to think. Any other? Yamini, you can take over. Any other questions?
Any other questions? Again, reiterating because of technical snag, we're not able to open up the chat box. Would anyone else ask?
Those were the two questions in chat box. Dr. Swapna, I think, has some question.
Yeah, one interesting question has been asked in the chat box. What is the prevalence of aripiprazole induced miscarriage? Because somewhere in the formulation it has been mentioned that query antipsychotic induced, right? Spontaneous abortion. Would like to. I would also be interested in knowing this.
Yes, ma'am. Ma'am, according to the CANMET guidelines, there is no evidence of any miscarriages or ectopic pregnancy with aripiprazole, ma'am. So it was one thing we thought of, but we got to know that there is no evidence for miscarriage or ectopic pregnancy with aripiprazole.
Why in the formulation it has been mentioned query antipsychotic induced? You were expecting this question to come up?
It could be a case report, ma'am, first of its kind.
Still, we have to write, right? I don't know, we cannot do it.
There are case reports, ma'am, of induced where there is no.
They are okay.
To support the same. Very less likely that it could be attributed to aripiprazole. Sorry.
Anyone else?
We don't have any other queries in the chat box. I think most of the things have been clarified.
Right. Maybe Dr. Sneha can just finish up with the prognostic factors that predominate.
Yeah, the prognostic factors for this patient, the good prognostic factors being female gender, better treatment response in mood disorders, identifiable precipitating factors in this episode, it is postpartum period, good premorbid functioning with adequate education and occupational attainment, absence of substance use, no family history of major psychiatric illness, good insight at the discharge, that is inside being 5/6, and adherence to follow-up and medications after discharge. The poor prognostic factors being early age of onset of mood disorder, recurrent episodes, including mixed and psychotic episodes, postpartum associated with high relapse risk in future pregnancy, need for polypharmacy and ECT indicating severity, functional impairment during episodes, especially caregiving responsibilities.
That we come to the end of today's presentation. I would certainly want to hear from our chairpersons. Any queries, questions, or any final comments based on what we've heard so far?
I think this has been quite an insightful case presentation by Dr. Anusha and Dr. Sneha, and quite a comprehensive, and we were able to answer most of the queries that has been put forward by the audience. And definitely it's a good initiative by IPSKC and by the Institute of Medical Sciences that this was held and people posted it very well. And I thank the IPSKC for giving this opportunity to take this session. And overall, I would say this was a case presentation by the Department of Psychiatry from the Institute of Medical Sciences.
Thank you, ma'am. Thank you for your kind comments. Kiran, sir, anything?
Yeah, I have a conflict of interest. It's my own department was presented. But anyway, the whole context of presenting this case was bipolarity in a female, particularly of reproductive age group, has multiple challenges. This patient did not have much of predisposition except for some temperamental traits. But in spite of that, had multiple episodes. There was good family support available. Responded very well to ECT in this episode. So we are also considering an option of maintenance ECT in the future. We have also started her on endoxifen, and there has been some confusion on the treatment, but because she responded to aripiprazole, later she was responding to risperidone with occasional oculogyric crisis. Eslicarbazepine was again better. So we had our own issues with handling the patient, whether it was lithium or divalproex or olanzapine, and everything has its own pros and cons. The emphasis was different epochs in a female's life led to a lot of vulnerability in this patient and a lot of treatment challenges. And it is ongoing with twins now and the family support now. Now it is predominantly she's staying with her husband. In-laws are coming occasionally. So there will be probably future challenges. So we are contemplating on how do we deal with these challenges. That was the whole gist of the experience of treating this patient. Again, before I hand over back to IPSKC, thanks to IPSKC for this wonderful opportunity. Thanks to my own department and the moderators for this wonderful conference. And also thanks to my other faculty, Dr. Sudarshan and Dr. Megha, who did a wonderful job in managing this patient. Thank you. Over to Dr. Kasturi, madam.
Thank you so much. It was a wonderful presentation. And it is good the thing to consider ladies, actually women mental health. And it is, a lot of queries are seeping in, but still long way to go. I think IPSKC will be continuing this monthly case conferences, and I think PG should attend this conferences. And the next year, I think the next time it will be from Rajarajeshwari. I request all the HODs as well as the PGs to attend it. Probably it will be on the last Wednesday. And thank you, Swapna ma'am and Dr. Kiran and all the team of YMS. It was a wonderful experience and we are also learning. And the thing is this, my question was, this lady was on Harpiprazole for 4 years. And that is a query for me. I don't know. And she had multiple abortions. I think we will have to look into this abortion and ARIP, which has not been very much considered here. I think I'll go and look into the literature regarding this. And one more query is that, suddenly, I don't know, are we supposed to start this patient on tablets other than lithium could have been considered? But, when we considered even in case of schizophrenia and schizoaffective, I think lithium could be a choice. But, I don't know. This is something which is also, and no point of time the depressive was given any challenge. Depressive is not at all considered, though you did specify about depressive illness and what is it. I think the history in due course could also throw some light on her. Anyway, it was a very good presentation and thank you very much.
Thank you, ma'am.
Christmas celebration.